Great. So it's my great pleasure to introduce Jishnu Das. I told Jishnu I'd give him a glowing introduction, and he told me not to, but I'm still going to say a couple of words. So Jishnu is a professor at the McCourt School of Public Policy at Georgetown. He's done some really fantastic work requiring very deep and longitudinal data collection in low-income countries, including the largest and longest running cohort study of learning outcomes in a low-income country. And he's also made a lot of advancements on measuring health outcomes in low-income contexts. His work has had a lot of policy influence and has led to the widespread adoption of training programs for informal providers in West Bengal, health facility inspections in Kenya, and networks for private sector providers in India. He's also won numerous awards, which I won't all list, and I'll turn it over to you, Jishnu.
Thanks, Natalie, and thank you for having me. It's a pleasure to be presenting in front of you guys. So this is joint work that I've been doing with Guadalupe Bedoya Lupe at the World Bank and Amy Dollinger also at the World Bank for the last 10 years. And it's on randomized regulations, the impact of inspections on health markets. And just, what Natalie didn't mention, but as she knows, I'm going to take the advantage of my older age and close to obsolescence to just give you a brief thing that, look, this is, literally the second time I'm presenting it. So I want to be very open about where I feel we're secure and where I think we need your feedback. So, as always, do feel free to question and point out where we need more work. But I'll also give you specific areas where we really need your feedback. And I kind of want to leave 10 minutes at the end just to have a broad discussion of the issues and kind of see where we should push forward on. Okay, with that introduction. So what's the motivation? So quality regulation and minimum quality standards are widely advocated for so-called mixed health systems in low and middle income countries. So mixed health systems are ones with public and private providers. Just to give you some numbers, 70% of primary care providers in India don't have formal qualifications. So in fact, most of India's primary care is provided by people who don't legally exist. In Kenya, one of the most advanced African countries in terms of regulation, only 2% of health facilities meet minimal patient safety standards. And in 5 of 45 African countries, a minimum quality standard regime is on the books, right? The others have not even thought about, okay, what should be a quality standard for our health facilities? But there are concerns, right? I mean, when we think about this, and this is always recommended in the recommendation or policy part of any health paper is, the government should have regulation and standards and stewardship. But there are serious concerns that economists have raised. Well, first of all, if there are no market failures, any minimum quality standard hurts consumers, right? I mean, we don't necessarily have quality standards. We might have safety standards, but we don't necessarily have quality standards for most commodities we buy, right? And the reason is, somebody who has low willingness to pay might be willing to buy a lower quality product. Somebody who has high willingness to pay might be willing to buy a high quality product. And we don't want to interfere in that. But even with market failures, depending on the market and cost structures, these minimum quality standards may end up hurting those with low willingness to pay, typically the poor. Turns out it's not just a theoretical concern. So there's one very nice paper on minimum quality standards of childcare from the US by Hotz and Chiao. And they show that this actually hurt the poor and benefit the rich, primarily because low quality facilities that were addressing the needs of the poor shut down, leaving the poor with nowhere to go, right? Two things with minimum quality standards in healthcare. First of all, there is no experimental work on this at all. So regulation is the oft-cited mantra for how to improve things. There is zero experimental work on what regulation does. In low-income countries, there aren't high-quality pieces as well. And I think part of the reason for that, which is going to be special to low-income countries, is concerns about state capacity, right? So this comes out in a number of different ways. But there are many, many examples, and I'm not going to list them all, but people around the room will know many of this, a lot of this work, which is regulations in low-income countries are often imperfectly implemented with multiple examples, whether from health, education, environment, taxation, or social policy. And at least the anthropologists, and Das and Poole here is actually my mother, not me. There is a lot of anthropological evidence that everyday state actions are actively negotiated between state representatives and citizens rather than being a diktat from above. Interestingly, the economists have started thinking about this quite seriously on what does imperfect implementation actually mean. And Esther Duflo and all have a very nice paper showing that this kind of regulatory discretion actually improves performance, because in their case, pollution inspectors targeted the worst performing firms rather than spreading out their thin resources exactly according to a regulation, right? So what we're going to do here is we're going to provide experimental market level, and I'll clarify what each of those things mean, study in 3 Kenyan counties of a regulatory reform of minimum quality standards. The key features are going to be the following. It's going to focus on patient safety. And the reason it focuses on patient safety, I work on quality quite a lot, is because it's one of the few measures of quality that we have that's unidirectional, right? So we can always say that somebody who got, a clinic that gave more sterile injections is better than one that gave fewer sterile injections, right? That's not true for a lot of other quality measures like antibiotics. Antibiotics are patient specific, which is why you keep getting into this issue of patient sorting in these places. Patient safety doesn't have that problem. It also has plausible link to health outcomes. Peter Piot, who worked a lot on Ebola, points out that a lot of the Ebola movement happened because of poor patient safety in health facilities. Second key feature, we work with the government. So this is not something where we are coming from outside and saying you should do this. We work primarily as advisors for the government, and I'll talk to you again about this, with 3 years of prep work with the 9 regulatory boards and councils who are responsible for regulation. And then we got cabinet approval, so approval from the parliament and the president for an experimental evaluation of the inspection system. And it's the first time I think we've managed, and anybody's managed, to put both public and private facilities on the same regulatory footing. So there was a big demand from the private healthcare guys saying, look, if we are going to be regulated, we want the public facilities to be regulated as well. There shouldn't be 2 different rules on the books. And we managed, everybody agreed, and that was done. Third part, it's the first market level randomization we have in health. So just to give you one idea, some idea of what that means, here's a market in our context. So this is, a market, say, with 3 healthcare providers. And here's another market that I'm going to call the control market. I just copied it just to make sure that we understand it's experimental. So on average, the 2 markets are identical. We are going to treat this market and we're going to let this market run as it will, right? And then we're going to come back a year after the intervention to assess outcomes in this market compared to this market. And that could include closures of facilities, movements of patients from one facility to the other. It could include new facilities coming in. So all those things will be included as part of the effect of the regulatory reform. Right? What are our contributions? So I think it's the first experimental evidence on the impacts of healthcare regulation, and it kind of firmly brings this idea of doing experimental evaluations of legal changes into this kind of mode of thinking about causal impacts. I should point out that we're going to find some fairly significant effects, and there have been very few studies. There are 3 on how to improve patient safety in these contexts. All of these have been evaluations of a group called SafeCare, which is a leading firm providing accreditation and quality improvement metrics. All of them show 0 to limited impact. And I do want to point out that these costs of these interventions are not being provided in the paper, but one study mentions thousands of dollars per health facility. So there's a fair bit of investment going into this following the kind of Ebola crisis and these questions about patient safety. Right? It's also the first experimental evaluation at market rather than facility level. I should point out a clear boundary of the study, and you should be aware of that, which is we are not going to we're not going to examine the impact of these minimum quality standards on health outcomes. The reason is when we started looking at this and asking how we could measure it on health outcomes, it turned out it would cost us somewhere between 10 and $20 million, because the way they do it is they go into facilities, sweep them for bacteria, and then test all these bacteria using various different ways. And it's a super expensive thing. So the way these are typically done is in 1 or 2 hospitals. We are going to be working with 1,200 facilities. And it just turned out that there was no appetite to say, let's measure health outcomes when we don't even know whether it's going to do anything. So, so that's where the boundary is.
Jishnu, can I ask you a quick question about your market?
Yeah.
So is the way we should think about these markets that if I'm a patient, like any, any potential clinic I would go to as either treatment or control, like, is that how you've defined the market? It's going to be like 5 clinics in a certain geographic area. Is that like a fair way to think about why you chose this market?
Yeah, I will show you a slide showing you exactly how we define that market, and then come back to what what concern is going to arise from that. So let's just hold on to that for 3 minutes, I think is what we're going to talk about, okay? So my emphasis is going to be on understanding state-implemented minimum quality services, standards, and the link between this and market structure. And there's a legitimate criticism that, look, if these minimum quality standards are not even demanded by patients, then maybe all of this is pointless. I mean, maybe you're measuring what's the color of the wall, which, by the way, is one of the standards in the Indian public sector stuff. We're not doing that. I'll show you that this is demanded by patients, right? So at least on that margin, we're fine. I haven't been in favor of these kind of structural reforms, which is what these are, because they typically have limited impacts on behavior. But 2 things, we really can't speak to what would happen if the regulation was around behavior rather than input. So I don't know what that would say. And 2 things in our favor. One is the tool we're going to use is very similar to what's used by the international organization called the Joint Commission International, which accredits hospitals around the world, right? So, there seems to be it's not a straw man that we're erupting or something we came up with by ourselves. It's something that's fairly standard in the field. And there is some evidence that these standards are at least necessary for improvements, although they may not be sufficient. Okay, so here's a preview of findings. We'll show in a first stage that the implementation was well carried out, but with delays and substantial departures from rules. I'll show you the main outcomes of the following. I'll show you that the scores, patient safety scores increased without an increase in patient level prices or a decline in patients. There was a reallocation of patients from private to public facilities driven by private facility closures. There was substantial exit and entry. But despite that, 93% of the improvement for patients is due to improvements within existing facilities rather than exit and entry and or reallocation. Those are the estimated costs. And then when I dive into mechanisms where really I need your feedback, I'm going to argue, speculatively, that there's less evidence of a pure price channel. I don't think it's right to say less evidence. I think there probably is a price channel for sure, which is regulators come and say you'll be shut down unless you improve, so you improve. But there's actually very little evidence for an informational channel, and there's some evidence of a market power channel. Okay, that's how I present this.
Jishnu, can I ask a quick question?
Please.
Do you know anything about congestion or waiting times at these clinics? Because I'm just wondering if the private providers are closing and people are being reallocated to the public sector, are they now having to wait longer?
Yep, we have all the congestion numbers and we have all the waiting times, and we actually observe spillover impacts on other things as well. I'll point those out when we come to it.
Wait, I'll be patient.
Yep. Waiting time is 7 minutes for that one. Okay, so let me just show you what the intervention was, because then the results will be fairly easy to look through once we get to until we get to the mechanisms. So before we come in and start working with them, the regulation of health facilities is that's a federal responsibility with 9 different boards and councils. So that's the medical board, the nursing board, the clinical officers board, the nutrition board, the something council. There are 9 of them. And prior to that, they were doing these regulations through sporadic inspection. So they would be done by the senior board and council members. They would decide, oh, we have 3 weeks off, let's hire a couple of cars and go to this region and we'll inspect a lot of facilities. There were no standard rules. There was no inspection tool. There was no standardized aggregation or scoring system. And there's very low capacity for follow-up. So when we started discussing them with the boards and councils, one thing they kept saying is, look, we do all these regulations, but we have no idea what happens. Maybe we shut down the facility, but 2 days later after we leave, it's open again, right? And generally, the adherence to patient safety regulation is low overall. Although I should point out that Kenya, when compared to other African countries and compared to India, is doing way better on its quality of medical care. Okay, this is our selection of counties. So these are the 47 counties in Kenya. We got administrative data on all the counties, and we did a market level analysis of how the markets are distributed. And then we went to the 47 county meeting, which they have once a month. We presented our stuff, and they wanted us to pick these 3 counties as representative. As they said, look, if you pick these 3 counties, it'll tell us roughly what would happen in all the country because it reflects the diversity. For those of you who do experimental work, you realize how much of a nightmare this is, but I think it buys us some notion of external validity in this study. Okay, this is Manisha's question on how we looked at the market. So here's what we do. We use something called a Z-center clustering algorithm. That's like a k-means algorithm for those who work on it. So we're going to start by picking a point, which is a facility, drawing a circle that's 4 kilometers around it, right? And then if there's any other facility in that 4 kilometers, so maybe there's another facility here, we're going to include that in the market, take the new centroid and draw another 4 kilometer thing around it, right? And once that has converged, we have defined a market. So these are 3 singleton markets that have only 1 facility. This is a market with 5 facilities, and this is a market with 3 facilities, right? And these examples below are exactly these examples of different types of markets. So this is a singleton facility market. This is a market with 3 facilities. And this, you can see, it's a bigger town, and it has something like 60 or 70 facilities, right? How do these, what are we going to do with these markets and how we work with them? So the reason why we choose this 4 kilometers is we do exit surveys, and 70% of the patients are living within 4 kilometers of the health facility visited. So it doesn't seem like a very bad idea for how to model these or think about these markets. Manisha, does that get at your question? Or
yeah, that was my question.
Thanks. Okay, great. Okay, so what are we going to do with these markets? We're going to allocate, so that we have 1,258 health facilities that we're going to allocate to 273 markets. They're going to be control 87 markets. And then there are going to be 2 treatment arms. One is going to be these inspections with enforcement, but another one is going to be these inspections with enforcement, and then we're going to put a scorecard on the facility, and I'll tell you what the scorecard is. So this is T1, think about it as T1 plus consumer information, right? In control, what's going to happen? Well, we can't prohibit inspection, so it's going to be business as usual inspections. In practice, it's going to be almost 0 inspections during this time by the regulatory boards and councils, which is kind of the norm, right? One other thing you should know, all facilities whether treatment or control receive a copy of the checklist and the regulation. So this was non-negotiable. It is a law. So everybody receives a copy, right? So if they want, they can, do the checklist for themselves at any point they want, right? Okay. What's the checklist? It's a 480 item checklist that we developed over 2 years. It's based on these SafeCare Essentials quality accreditation tools, and it's now an accepted standard in this field. What's very interesting is it has some things that are really expensive. So for example, a sluice room with a sluicing sink or a drainage system in the labor department. These are expensive things to do for a facility, right? It also has really cheap things. The cheapest things in the checklist are these standard operating procedures where essentially you either take a page out of the manual and paste it on the wall, or you get a printout of how to operate whatever machine is. It's a tiny machine, a tiny hematocrit or something, and you paste it on the wall, right? And what was really interesting is we did about 2 years of pilot visits. So, I've done about 15 inspections with the inspectors. Amy has probably done close to 100. And we would come back to them and we did all these things where we said, look, are you going to equally weight these things, right? Or do you want, us to come up with different weighting schemes? And we came up with various different weighting schemes for them. What was very interesting is they said they wanted, again and again, they were super clear, they wanted everything equally weighted. And I think it's interesting because they said that's how trust is going to develop. If we try and do these weighted things, nobody is going to believe us, even though we were doing it with tablets, so it could be done right on the spot, right? They just thought it was so much more important to develop the trust rather than fight over where did this come from, right? Second thing, we know with all these kinds of measures, there's going to be mean reversion, right? You are going to have, whether it's due to tiny shocks or whether it's due to measurement error, you're going to have mean reversion, right? That turned out to be really hard to explain to the regulatory boards ex ante. And you'll see that it's there in the data, right? So how do we think about mean reversion in terms of a checklist and what that means? We'll come to that as we go along. Finally, in practice, we thought these would be punitive, but they were not. They were supportive, right? So the best inspectors would kind of complete the checklist, and they were sympathetic but firm. I mean, I still remember an inspection I did in a slum in Nairobi, where they said you don't have you don't have a waste incinerator. The guys were like, how the hell am I going to put in a waste incinerator in the middle of a slum, right? And he said, look, it's not, you really need this because otherwise you're going to harm the population. Why don't you call up a firm that will come and pick up the waste from you and take it to an incinerator, right? And actually, when we went back, the person had done that. So the conversations would be more along the line of, I understand this will be expensive, but how can we have a situation? We are trying to be a modern country where you don't have an emergency trade. What will you do if someone dies? So it's kind of interesting, right? I mean, just to keep at the back of your mind that these were really kind of supportive inspections, right? Just some ideas about what these measures look like. So hygiene protocols, all of these are these printed out forms. On the other hand, you could do low-cost supplies. Well, at the time we were doing it, face masks were low-cost supplies. I don't know whether they still are, but you had fairly expensive infrastructure items, ventilation, right? Power supply, so that's an emergency generator. Changing the emergency room structure. These were expensive things for these guys to do, right? And here are the last part I need you to get on this thing, which is these guys were really ambitious. So I'll show you most of the facilities are going to fall here in the baseline, right? And we did this. We did like 50, 60 pilots. I think we did like 150, not in these areas, around Nairobi, around other places, showing them time and again that this is where the majority was. But they came up with this list, which they did not want to budge on, which is they said, look, the minimum patient safety is 60%, and that's what we're aiming for, right? So at some level, all our facilities are going to be subject to some kind of safety requirement, right? So just keep that at the back of your mind as we go along. And then the last part in the information arm, after the inspections are done, the scorecards are pasted on the door of the facility. What do those scorecards look like? Well, they have a big letter grade. So if you've been to New York and you know what restaurant report cards look like, they look exactly like that. We did focus groups with people. They seem to like it. It gives you a letter grade. It gives you your score, and then it has this bunch of stuff here on what the scorecard is. One important piece is you could externally verify it. You could SMS a call, and we kept SMSing and calling to see whether that was working, and it seemed to be working. So that's the information arm in this case. Okay. Last thing, we'll see that a lot of facilities didn't have licenses. So what does it mean to become formal? It's money and some kind of a process, but it's not a very expensive, it's not a very onerous process. This works, right? 1 to 4 weeks for the licensing time from these different boards, it tends to work. But note that if you add it all together, because you have to get licenses from all these boards separately. So if you have a clinical officer in your clinic, then you have to have a license from this guys. If you also have a nurse, you've got to get a license from these guys as well, right? So this is an expensive story for these facilities when we move on. Okay, this is our experiment. We are going to start with the baseline in January, February 2015. Then there are going to be the usual delays, contracting, training, all of this kind of stuff. So in November 2016, the intervention was supposed to start in March 2015. By November 2016, it's not happening yet. So we do a partial update of the census. Then we randomize. And then finally, this starts around November 2016 with a treatment rollout. And just to give you some idea of how much churn there is in this market, between the treatment rollout and the end line, we are going to see 262 new facilities come in and 201 of them exit, right? So if you add those two up, exit and entry is like 400 out of 1258. 33% of firms are going in, coming out during this time, right? So it's a, really active private market. So this is of all facilities. So if you think about it only in terms of private, maybe 50% of private facilities are closing down or coming back, coming new in the market each year. Okay. So what are the things that we thought were important from the baseline? So we have a lot of data. I'll take you through it as we go along on this story. What are the things that we thought were important from the market structure? So these are mixed systems. So 36% of the facilities are public, but they account for 71% of overall patients. 61% of these private facilities that received an inspection, they did not have a license. So that's 43%, or had an expired license. Now, here's the interesting part, which is most of the action on where patients are going to be markets of 3 or more healthcare providers. And I've been saying, look, I've been trying to convince people for a while that, look, the world out there is not, markets where there's a single person. And in fact, single clinic markets account for only 11% of patient visits, right? So 6% of facilities are singleton. 23% are in markets with 2 to 4 providers, and 52% are in markets with 8 or more providers. Okay. 2 more things about this environment that are really important, and unlike India, where my other work is, we almost never see only private providers. Only 12% of markets have only private and no public providers, which is super interesting and different from India. And 92% of providers that received an inspection when were found without a license are in markets with 3 or more providers. So it's always going to mean that these unlicensed guys, they are in markets where patients have another option. right? And that option is actually, the public option, right? Last thing, so here are our baseline scores, and here are the benchmarks that these guys wanted. So this is the 40% minimally compliant benchmark, and this is the 60% substantially compliant benchmark. And you can see that people were, mostly below the 40% level to begin with. Okay, two things, partly dealing with Natalie's thing. One thing here, so here I've just tried to show you these different market sizes. Two or three interesting things. One is public facilities tend to be slightly higher on this score in the bigger markets. And I think that's partly because they're bigger facilities and they have more access to funds, more access to people. Private facilities, not really that much. Their quality is pretty independent of market size. Second thing, people don't usually recognize this, but most facilities in low-income countries are running at massive excess capacity. I mean, think of these numbers. That's 10 to 12 patients a day, right? They're spending about 8 to 10 minutes maximum per patient. So they're seeing patients for about an hour and a half to 2 hours a day. It looks like the public is a lot more, but remember the public also has more healthcare workers. So if you divide this through by healthcare workers, it's not that they have many more per healthcare worker. And that's actually a statistic I should give, right? One last piece, there are user charges still, even though they're not supposed to be, and they're for specific services and for different things. So you see some charging in the public sector. Private sector, you see very clearly, the more they are in a city, the higher their prices. Okay. This is the market churn. So I'm just showing you the private facilities in the control group, and kind of couple of things. One is nobody is being closed by the government here. And this 3% was because we had a mistake in our randomization at the beginning rather than anything else. But nobody is being closed by the government in general. Despite that, there's a very clear pattern where if you are low quality and unlicensed, you're just going to be, these are facilities closing and opening very, very often, right? At the top end is where you're getting stability in this market in general. Finally, prices. So does this score that we are measuring actually matter? Or is it something completely orthogonal to everything? Well, it actually tends to matter, right? So what we're correlating here is looking at the private facilities and looking at the fees they charge against our checklist score. Remember that the average fee in these markets is somewhere about $5, right? $4 to $5. So one standard deviation increase in the score gets you an additional $5, right? This is something that my co-author Lupe decided was impossible because patients don't know anything. So she tried everything she could to kill it. So these are these lasso regressions with post-double selection. And there are literally 400 variables she put in there to try and kill this result. It doesn't budge, right? So it seems very, very clear that in the public facilities, it doesn't matter. In the private facilities, the higher your score, the higher the price. And that's our first indication that there's information in the market around quality. Okay. So let me stop there for a minute and see if there are any questions at this point or whether the intervention and the setup is sufficiently clear. Do you want me to move on? Yeah. Okay. So how did the intervention work? We were fairly surprised with how well different pieces of it worked. So here's the inspections. Did the health facilities receive a copy of the checklist? Yes. Did they receive at least one inspection? Yes. All kinds of things. They did well. Were scorecards posted? Yes. Interestingly, did the health facilities leave the scorecards? Yes, 90% of them had it on their door when we'd made random checks throughout the thing and 2 years later, right? So the scorecards remained, so on average, there was a lot of fealty with the intervention. One piece, so this is not that that clear, right? So the way closures were implemented was that the team needed to come from Nairobi, and there used to be huge community discussions about it. But even then, 27% of health facilities are closed, but they're very important delays, right? And by the time the intervention ends, there's still many, many facilities that might have been closed, but never are closed. And we are going to have this question of, okay, so what should facilities expect from this rule, right? One other thing, just because I really like this picture, we set up everything on a tablet, so we have high frequency data on everything. This is how inspections worked. And they, whenever there were delays, they kept saying, oh, it's because of national issues. The biggest reason why inspections went slowly and did not happen were two. Either inspectors were absent or the vehicles broke down. Okay. And the worst of it is these were totally orthogonal to each other. So on the day the inspectors were absent, the vehicles would break down, right? And the days the vehicles were working, the inspectors would be absent. And there was like zero. So literally because of that, if we could just get the vehicles on the day the inspectors were there, which we did over here with a short exercise, just to show them that the marginal cost per inspection would go down, right? We could have got way more efficiency, but we were like, look, we are hands off. This is their deal. They got to figure this out, right? But, just for those who are doing these things, make sure the vehicles have gas and, our work. Right? Okay, so with that, I think we're down into what are the results and what are we seeing coming from this thing. And it's going to be really easy in terms of the reduced form to think about it. So we are going to look at outcomes in facility I in market M. Market M is going to be treated or untreated. And right now, throughout, I'm going to give you pooled results from the two different interventions till we come to the mechanisms. There are 16 randomization strata by county and number of facilities in the market. Two more things. There are always two ways to do this. You can weight it by the number of patients, which is the actual welfare increase, or you can leave it unweighted. For theory, for relation to theory, you want to do the unweighted because that's essentially saying how much did you charge and what quality did you choose. And then for welfare and for other stuff, which I'll point out to, we'll do patient-weighted outcomes. And then the only other departure from our standard stuff is because we have so much churn, we're going to use baseline market level variables, not facility level variables, right? And we will depart from this, and I will point out when we make that departure. But just remember, the moment we depart from it, we're going to work with 65% of the data. Okay, here are treatment effects. So overall treatment effects, a substantial increase in the score, about 0.5 standard deviations. An increase in the unweighted prices, no change in the overall outpatients, big increase in closures of 68%, right? And no change in entry of new facilities into these markets.
Jishnu, I'm guessing you're going to go to this in a slide or two, but is the JHIC score improvement explained by the closures entirely, or although also intensive margin improvements?
Oh, I will show you exactly that.
Okay.
Waiting time is now 5 minutes for that one. Yeah.
No. Forget about the waiting time.
I'll show you exactly those results.
Yeah. Okay.
These are the treatment effects with a private facilities, differentiating the private and public. And the two things I want to pick out is, the improvement is larger in the private facilities, right? The second point that I want to pick out is there's a reallocation of patients from private to public facilities. So private facilities are losing patients. You have to be careful. It's not that private facilities are losing patients, right? It's that because the overall effect on private is zero, public facilities are gaining patients, but because there are many, many private facilities and fewer public, all the private facilities are losing a little bit. I'll show you where those are coming from these closures, and the public facilities are picking those up, right? And then you can see they didn't close any public facilities, they closed private facilities. And again, no impact on entry. This is the result with the unlicensed facilities. Remember, 61% of these facilities didn't have a license or they were expired. That's where all our closures are coming from, right? So we have a 58% increase in closures among the unlicensed guys. They are the people who are losing patients, presumably because of these closures. They're not changing their price, but they're improving less than the other guys, right? They are improving, it's a significant effect, but the unlicensed improvement is 0.55 standard deviations. The licensed guys is 0.76 standard deviations. Forget this for a second. Okay, now coming to Natalie's issue, we want to think about where are these effects coming from. So this is what we've done. First, we want to work with weighted patient effect. So this is now at the patient level rather than at the facility level. And similar results, except that this private facility result is not significant. And in general, our effects are a little smaller, which means that the improvements are less among the big facilities, right, than among smaller facilities. That's why when I'm weighting by patients, it's going down a little bit. And also, the prices are not changing once I weight by patients. So these increases we are seeing are coming in small facilities. And then here's what we, so what we find then finally on whether the poor were badly affected by this closures and stuff is we did exit surveys of 11,000 patients and we constructed asset indices based on ownership of key assets. And if the poor had dropped out, we should have seen a mean increase in wealth among those visiting facilities in treated areas, right? And we have tried this every way. We have done it with quantiles, we have done it with means, medians, and we've done it with distributions. You see this in the distributions, there is just no difference in the wealth of patients who are coming in the control and the treatment group. So we're pretty confident that there was zero loss to anybody from this treatment, and along a margin, bunch of, at least on these, if you believe these scores, this thing actually improved patient safety in these areas. Right? So that was this summary. So now coming to Natalie's question, so we try and look at where did this change in patient safety come from, right? And we're going to decompose it into 5 different terms. It can come because continuing facilities increase their quality. So no reallocation, but the facilities that were there already improved their quality. It could happen because patients moved to facilities that were higher quality. That's reallocation, or what we call between. It can happen because of new entry. So maybe the facilities that were entering were really good. Or it could happen because facilities that were exiting were really bad, right? And then there's this tricky one that says, what's the covariance between facilities that raise quality and patient reallocation? Maybe the ones who raise quality the most also gain the most patients. So you can decompose it into these 5 terms for each market, and then look at the difference between treatment and control. And here's the interesting thing, despite all this exit, our total change of 3 points on the JHIC score, 93% is coming from improvements within facilities, and less than 5% is coming from exit, right? And that's primarily because the guys who are exiting are a tiny share of the market. And I think this is something important for us to get is, look, we worry a lot about this lower part of the market, but patients are discounting it a lot. I mean, they're not accounting for a big share of what's going on at all. They're accounting for a big share of facilities, but not of patients, right? 2 more results that I just wanted to point out to you on the reduced form, and then I'll stop before we go into the mechanisms. One is we don't find spillovers. So we can do the strategy that Ted Miguel and Michael Kramer use of saying, since these markets were randomly allocated, can we look at a place that had randomly many other treated areas close by versus a place that didn't, and we don't find any spillover effects? And the last thing, did this, what happens as facilities are in this whole process longer and longer? Well, there's no fade out. And remember, partly this is as facilities are in longer and longer, they're going to be inspected more often. But it looks like, as they stay in the process more and more, their improvement is even higher, right? I mean, it's the people who were inspected right at the end who are showing the lowest improvements in our data. Okay, 2 more results, and then I promise I'll stop on the reduced form and we can discuss this. What happens with closures and inactivity? So here's how closures work. For the licensed guys, they're just not going to be closed by the government regardless of where they are. For the unlicensed, it's pretty clear. If you were low quality, you were getting closed down with a really high probability, right? And they remain inactive at baseline, but this probability is going down. Right? So we tried to look at this in 2 different ways. We can't just look at markets with and without closure, because closure is part of the treatment, sure, but facilities that were closed also have characteristics that make them more likely to close in the control, right? So we saw exactly this pattern earlier when we looked at the control facilities, which is, where did the market churn go? Yeah, here, which is, look, again, the same way, the facilities that were unlicensed and in the lowest group were most likely to close in control as well, right? So what we tried to do to account for that, and here feedback would be very welcome. We use standard machine learning tools to model closure. The key data is the availability of licensing data, which we get for every facility. And then we do 2 things. We either estimate the impact of closure as heterogeneity in the treatment effect, following Alberto Abadi's paper and work on endogenous stratification, or we think about closures as a mediating outcome following the mediation literature, right? So just to make it very clear, here's our machine learning algorithm compared to simpler things. And as somebody who likes simpler things, I was quite happy that, we don't find that much. If we just use unlicensed, we get a true positive prediction rate of 84%, but also bigger false positives of 36%. If we use a standard regression model, we are getting much worse on true positives, better on false positives. And if we use a random forest, then we're getting pretty good at predicting who's going to be closed and pretty decent at reducing our false positivity rates. So we're going to use this random forest right now. And the LU is not the English for restroom, it's the leave one out estimation that Alberto proposes to look at heterogeneity. So here's the 2 things we do. We say the first, modeled as heterogeneity, what we ask is there a difference in market shares depending on how many facilities have baseline characteristics that make them more likely to close in the treatment group? So we are going to look at, so for example, here, we are going to look at a control group market that has 0 facilities that are likely to close and compare it to a treatment group market that has 0 facilities that are likely to close, right? Here, we are going to look at a control market that has more than 3 facilities likely to close, predicted to be likely to close, and compare that to a treated market where we have 3 or more facilities likely to close. And the basic result seems to be that this increase in public stuff is mediated by closures, not mediated, is driven by heterogeneity in closures. And that's particularly coming from this licensed, unlicensed state, right? So if you're an unlicensed provider and you're in the market, in a market where there are many facilities likely to close, you are losing a ton of market share, right? So it seems to be that this is, heterogeneity in closure rates. The other way we do it is we look at it from a mediation point of view, and that's a separate question. because it's asking, does the regulatory change cause a reallocation of patients from private to public independent of the mediator, which in this case is facility closures? So we are asking, imagine there were no facility closures, would we still see this reallocation from private to public? And again, the answer seems to be yes. We see this increase in public in general, but it's much lower and insignificant when we mediate it with closures. We see a loss among private providers in general, but that loss goes away once we mediate it through closures. And similarly for licensed and unlicensed providers. So it seems like the general story is everything improved. Yes, facilities were closed down, but because they had all the facilities that were closed down tended to have a public facility close by, these guys just moved to the public facilities. At the end, this reallocation doesn't really matter that much because the quality of the guys who shut down and the public facility was kind of similar or even slightly better in equilibrium. Okay. Last one, these non-incentivized outcomes that Natalie and Manisha were asking about, we find across multiple outcomes that there's no change in the public sector, right? On non-incentivized outcomes. So, no change in patients. There's no change in any of these in the public sector. Physical exams, for example, is a marker of how well the person's taking care of you. No change. Among healthcare worker compliance with infection prevention and control, we don't find worsening. So around all kinds of effects, we're basically seeing that the things that were not incentivized didn't get worse in the public sector, and they certainly didn't get worse in the private. In some cases, they seem to have improved. So that's my summary of all these results. So I want to stop here maybe for 5 minutes before we jump into the mechanisms and see whether people have thoughts on what the overall results look like. Is that good? Should we move on? Okay. Okay. So here's the part that where things start, where we try and look at, okay, what is the framework? What are the mechanisms? What's the market structure? And what's the connection between that? And I have to, be very frank here that, look, first of all, I'd love some discussion on it, partly because, at the end of the day, the public sector is 72% of all patients, right? And none of these frameworks from theory are going to say anything about public sectors and how they react, right? So that's going to be kind of out of the model, so to speak. And in a way that seemed kind of weird. We don't have a good mechanism for why the public sector may or may not improve in this case. But also you'll see there's a really interesting question of how do we think about regulatory changes in these structures, right? So let me just show you what the models in the literature are and how much we're able to get at this in this place, right? So there are two canonical models with different sources of market failure. One is a model by Carl Shapiro in 1986. And that model works somewhat like this. There are firms that live for 2 periods, and you decide in period 0 whether you want to be high or low quality, right? People don't know whether you're high or low quality to begin with. So in the second period, it becomes known whether you're high or low quality. But in the first period, there's always a pooling equilibrium. That is, nobody has any clue whether you're high or low. As a result, everybody's price in period 1 is the same. So price in period 1 of high is equal to price in period 1 of low, right? In the second period, some firms, choose H because they're going to receive an extra profit in period 2. So the guys who are H are going to get some P2 of H that is going to be bigger than their cost of being H. Okay. In this market, what happens when you put in minimum quality is that this L goes up, right? Because the L went up, the pooling price in period 1 is going to also increase, generally because the average quality in the market is now higher, right? Because L went up. As a result of that, in period 2, you don't need to push up the high prices that much, right? The H guys are already getting higher prices in period 1, so they can get a lower premium in period 2 and still choose to be H, right? So what happens in these models is in Shapiro's model is that consumers with a higher willingness to pay are going to be better off because the prices for H is now lower, right? And the low willingness to pay consumers may be hurt because the prices are higher in period 1, right? Shapiro notes that as long as this MQS, this minimum quality standard, is not set too high, consumers who exit are people who were on the margin of choosing to consume or not, and maybe their welfare won't be that badly hurt. But one thing to result in this model is that the central market failure is going to be asymmetric information. People don't know. People can't tell who's high or low quality in the first period, right? And that feature, that if the market is separating, we see higher prices for H and lower prices for L, then information with lower prices for high quality applies to a bunch of different modeling structures, right? So the other canonical model in this literature is Wolinski's 1983, and Tahir Andrabi and I and Asim Khwaja have a paper from 2016 showing exactly that in education, right? I want to contrast that with another model, which is due to Ronen in 1991, which is just that there are two firms in a vertically differentiated oligopoly. So there's one firm here, one firm here. A standard feature of these models is firms will not locate in the center. They will push away because pushing away gives them a little bit of market power, right? That allows them to charge prices bigger than the marginal cost. When you put in a minimum quality standard, the low guy who was here is going to move somewhere there. But as a result, this high person here is going to feel more pressure from here and move out furthermore, right? In this market, there's no information asymmetry. The source of market inefficiency is going to be the oligopoly structure of the market, the fact that firms have some market power, right? And in this model, minimum quality standards can actually unambiguously improve consumer welfare. It's the firms who are going to be worse off, right? So I think understanding these sources are important for regulatory policy, but it turns out that distinguishing the source is going to be really tricky, right? Partly because these models themselves are not that easy to distinguish. Both of them suggest improvements in the higher end of the market. And it really comes down to, does information make a difference, which it should in Shapiro's model, but not in Ronen's? Also, Shapiro's model predicts that you should see a decline in prices of high quality firms. Ronen suggests that firms will remain on an existing price quality gradient. Right? In our case, the biggest problem we're going to find is the following, right? So the biggest issue that we are going to find is the following. So think about, why did firms improve? Well, it could be price incentives. Facilities were told to improve or face sanctions, and therefore they improved. Or it could be these equilibrium channels where patients had information problems, and therefore regulations combined with information matter. Or it could be these market power channels, right? Maybe the guy below improves, and that's why you improve as well. The problem that we're going to have is facilities are going to choose investments to maximize their expected profits. Well, what's their expected profit? It's the expected probability of not being closed, given that you make some investments, and the profits given that you make those investments, right? The market structure arguments are going to come through this term. What are your profits conditional on investments? Your regulatory arguments come from this first term. which is what is your expected probability of not being closed if you make these investments? And the problem is this expectation. What did firms believe about whether they would be closed if they didn't make changes? That's never going to be observed in the data, right? I mean, that's going to be the fundamental problem we face once regulation is kind of uncertain, right? So for example, we never see closures for high performing facilities, even when they're unlicensed. Is that because they improved or because they wouldn't be closed even if they didn't improve? Right? So that's the first problem we have. The second is it's even hard to figure out what is your expectation of your checklist given your investment. Because I'll show you that measurement error is going to mean there's mean reversion, and not clear to me at all that facilities actually understand this. So the way I want you to think about the results right now is to kind of treat them as theory-driven information on heterogeneity of treatment effects, and perhaps the channels they're suggestive of, and then hopefully we can discuss how much to push on this further. Right? So let me show you 5 results, and then I'll try and stop. What are the implications of the price incentives channel? So you have the regulator come to you and say, guys, you got to improve your checklist score, otherwise you're going to be closed down, right? You should then focus on the cheap and easy to fix things first. And you should focus on getting just over the threshold, right? You don't want to be closed down. We don't find either of these, right? So what did facilities actually do? We have divided up here all these checklist items into lowest cost, low cost, medium cost, high cost, whether they were marginal investments or fixed investments. And one thing I do want to point out is these lowest cost items were the bulk, were a lot of the checklist, right? What's very interesting is they are doing more of the high cost items, right? Not necessarily more, but they're doing a lot of the high cost items. And they're doing some of the lowest costs, but that's not all they're doing, right? What are these lowest cost items? It's essentially printing, it's essentially printing out standard operating protocols. That's a huge part of these low cost items, right? You just print out a sheet of paper and paste it on the wall, right? But that's not what they're doing. They're doing infrastructure changes. They're making equipment changes. They're buying supplies, right? So they're doing pretty serious stuff. And even more so in the private facilities, right? These guys are really investing in infrastructure as a result of this. They're really investing in these low-cost supplies as a result of this. They're really, they are investing in medium cost supplies as a result of this, right? So it doesn't seem like they're making only these low cost investments, right? In fact, you can calibrate this and just say, look, if they had just printed out these sheets of paper and pasted it on the wall, what would have happened? And they would have all gone into the top lists immediately. So what we see instead is they went minimally compliant, came down from 70 to 48. Well, this is a control treatment comparison. It would have been 0 if they had just printed out these things, right? Partially compliant goes up, but it would have, because people move from here to here, but frankly, they could have moved all the way from here to here or here to here just by doing these low cost items. We can do this in more fancy ways using psychometrics and trying to see whether they increase difficult or easy items. It's basically the same story. And we can also look at whether they tried to get just over the threshold. So this is, preliminary, but we do this McCrary density tests. And again, there's just no evidence that they're trying to hit above the threshold, right? They are making a bunch of investments that are not, that are part of the checklist, but are clearly not the easiest way to meet your regulatory burden.
Sorry, can I ask a question about that?
Yeah.
So, Adrian, so did you talk to the facilities and ask how are these inside of the firm, these things implemented? So like, they face this new list, they have to make a bunch of changes, but how does that get communicated inside, or how does that get implemented de facto? Like, who's making the decisions? And because I can imagine, well, probably a lot of stories, but kind of a couple of stories. One is that different parts of the facilities get this information, and each of them then undertake whatever it is that they think that they can do, and maybe they're just, it's not centralized, so they're not making the decisions in the way that you are, by looking at the overall and kind of thinking what's the cost minimizing way of going. Another one is that maybe it is centralized, but they themselves different weighting on these criteria, and maybe
Exactly.
that some of these things that are expensive may be more profitable or something, or they care about them more. I mean, I don't know. Did you talk to them? I don't know what they might have said about that.
Yeah, I mean, we talked to a lot of facilities, and we're trying to do this exactly in the data. So they did say, look, I think the way it worked out was everybody realized that this kind of statement of purposes is not something that's really going to help patients. So I think they came out, at least among the private facilities, and we're trying to test this in the data, the changes they made were the ones that patients cared about more and that they could visibly advertise, rather than things that were part of the checklist, but unclear whether that would be important overall. But this is something, this is a great question. Let me try and think about it more and have a better answer for you next time.
Jishnu, just thinking about this result, which is super interesting, in light of your theoretical framework, did you look at all kind of breaking this down by, some kind of baseline quality measure?
Yeah.
Because if we have these kind of separating equilibria type things, you might expect that the guys on the high end are going to be doing these kind of high end improvements to signal the quality.
Yeah, so give me, this is 2 slides from now, but also if you give me 5 minutes, I'm done in 5 minutes, and then we can just have an open discussion about what to do in this, right? So,
Sounds good.
so that's what these guys were doing. It doesn't seem to be meeting the regulatory hurdles, right? It doesn't seem to be how do I minimize my cost to meet regulatory burden? Remember also we had this entire arm with these scorecards, right? Where we gave this information to people. Here's the interesting thing. On no outcome do we see any difference between the arm with scorecards and the arm without the scorecards, right? So giving more information in the form of the scorecards had absolutely no impact on any of the outcomes we measured, right? Now, for those who have done these information interventions, the key problem is always, well, was it correctly, was it salient enough? Did people see it? Did it really matter? I want to make 2 points there. One is, look, at the in-charge level, it clearly made a difference, right? I mean, they knew there was a scorecard. They were much more aware, they were aware of the new legislation. Even at the patient level, some of them noticed it. Two things, right? One is, even if the patients didn't notice it, that tells you that the facility in charges were not advertising these. After all, we gave them an externally verifiable score, right? And when we had done this previously in Pakistan, some of the schools put up huge banners, right? Saying, top school in village or whatever, right? They just went to, they went to town advertising their performance. These guys didn't do it, right? I mean, they didn't seem to care that much, right? Second point, we did see an improvement, right? If the information, didn't reach anybody or didn't matter, it's not our improvement didn't come from improved information. Right? That's the point we want to make, that there's no way that if the arm without if the arm with information had no changes compared to without, it's just unlikely that the arm where we gave no information actually resulted in more information than the arm with information. That's all we need, right? So all we're trying to claim here is that the changes we see didn't come from more information to patients. That's the weak claim that we're trying to make here. Okay, here's the questions that Natalie was asking. So the ideal test for these kind of market power channels like the Ronen paper is, did the facilities with lower expected probability of closure also improve, right? So we don't observe the counterfactual closure rates conditional on zero investment, which is kind of what you need. And Natalie, the problem is that 1/3 of a sample has entered or exited. So for them, we are not going to have baseline scores, right? So let me show you what we have done and then stop there. So let me show you 3 results. First of all, worth just staring at the histograms of scores in the public and private facilities. And what I found very interesting was, first of all, as we saw with the McCrary density test, we are not getting any big increases at the thresholds. But also, this is really the key threshold you wanted to cross. But a lot of firms are now in this kind of area. Pretty big changes on that side of the distribution, right? And kind of similar with public, right? They did go until up to this point. Here's how I wanted to, here's where things get complicated with respect to what did facilities expect or not expect. So I'm just showing you here, let's just look at this. These are the unlicensed facilities at randomization. So this doesn't include the new facilities that came in. And look at this, a lot of these guys are closed down, right? These guys are not, but perhaps these guys are not closed down because more of them go and get a license, right? But then on the other hand, the guys who did not get the license, right? The guys who remained open, even in this group, 75% of them haven't bothered to get a license. So what is your expectation of whether you will be closed down and whether you can reopen 5 days later? It's not clear in this from this regulation. So that's the first part. And the second part is, look at the mean reversion, right? It's so clear that if you were low down and in the control, you improved, right? But if you were high up, you actually went down just because of the measurement error in these scores, right? So the treatment guys at the top, they're kind of having to run to stand still, right? So mean reversion is going to give you another reason why they might, just from regulation, be forced to improve, because if they don't improve, they'll actually go down. Right? Having said that, so keeping that at the back of your mind, here are quantile treatment effects, which is the improvement is happening at the top of the distribution, right? It also happening throughout, but it's bigger and bigger at the top of the distribution. We might have expected that with a regulatory change, it's bigger at the bottom of the distribution. That's not happening. And when you break this up by market sizes, this one don't look at because there's just not enough sample. We shouldn't even have it here. What I found fairly interesting is, look, whether it's public or private, it's the top end of the market that seems to be responding in public, right? And it's the top end of the market that seems to be responding in private as well, right? So usually with the regulatory, with the minimum quality standards, you'd expect the movement to be at the bottom and almost nothing at the top. And what we are finding is, yes, there are movements at the bottom, but there's also a lot of movement at the top, right? And I kind of want to, so I want to kind of leave it there. And Natalie, these are the prices that we were talking about. And again, the movement is happening at the top for the private facilities, right? It's the top of the distribution that's moving out. And then we can do it with baseline scores, but remember, we are losing 1/3 of our sample in this case due to exit and entry. And again, we see if you're above the threshold, you are getting a change, an increase in your price if you're in the treatment group, right? So that was the last one. So, here's my discussion. So on the reduced form, I think we find increased quality. We find significant increases in closures of unlicensed low scoring facilities, significant reallocation. No evidence of decline in care seeking, especially among the poor. So one place to leave the paper is just that, to say, look, at the end of the day, We have a minimum quality standard implemented by the government in a low capacity setting, and we get fairly large improvements. Well, fairly large, not, we can debate, but we get improvements, right? Despite the fact that we get substantial closures. And that itself seems to be a new result, something we can that I think is important as the first study of regulation in these markets. On the mechanisms, love your feedback. How do you think this goes? Where do you think the problems are, and where further we can push on this? So let me stop there. And in fact, I'm just going to stop the share and kind of see if we can, what the views are here on how to think about this. Thank you so much.
Sorry, question there. So
yeah,
for your results at the top end of the market, so I think in other settings, one might see is that maybe what the hospitals care about is a rank within the market, right? So
okay.
like you want to remain the #1 hospital in this area or something like that. And so if that's how patients think and how hospitals react, then you can see kind of how pushing the quality at the bottom forces everyone all the way to the top to kind of step up, because people think to themselves, I just want to go to the best hospital for X, but so my question is, how do the firms, the providers know this experiment is taking place at the market level? Do they know?
Yes, absolutely. I mean, they know that fairly well, because remember, the markets are really constrained. And anytime we would go to the markets, it would be very clear. Everybody knew that this is going on.
Right, because then I think that that's really important, and that might explain kind of this kind of mechanism. I mean, I don't know if they advertise themselves in certain ways, but maybe that's kind of what's going on.
So what would you suggest as a test for that? Rank test? So, construct rank within the market and see.
I don't know. I don't know exactly how to think about this.
Okay. Let me think about it. I mean,
I just know here in the US anyway, just anecdotally, hospitals, I mean, UCLA, has an ad like ranked #1 in the nation or top 5 in the nation. And patients often frequently think that way when they talk about, when they are thinking about choice, when they have a choice, and they often think about either what's the most convenient place or what's the best place or some combination of these convenient and best, and so they tend to rank places rather than, compare them in some kind of broad quality level.
Okay.
I wonder if the same thing happens in schools, when people.
Yeah, no, because I mean, that's just so important for us, because if that's what's happening, then these minimum quality standards are just going to help enormously, because it's going to push up quality throughout the distribution.
Right.
That's going to be a really much bigger welfare effect than from just moving the bottom, right?
Yeah, and I don't know how to check for this, but
yeah, no, that's a great point. So let me think about it and see how we can check for that.
I've talked a lot, so if somebody else has a question, feel free to unmute, and otherwise I'll ask Jishnu a question. So I was trying to understand a bit more about what the incentives for the public guys who are already compliant are. So I think Adrian, because I assume they are not like profit maximizing the way the private guys are. So they're not worried about losing market share. So can you just kind of shed some light about what you think the public guys are maximizing?
That's a tough one. I mean, it's not totally clear to me, because usually, so I don't think we have problematized the public sector enough, and I don't think we understand it enough. You are right. I should be thinking harder about that. It's partly because I've been focused on the private part of it. but at the end, the public sector is where the action is, right? They're seeing 70% of the patients. So let me think about that, especially for the guys who are already above the top and how we can work with that. Give me a little bit, I'll think more about that.
Yeah, because I was thinking about, so it kind of might shed light on mechanisms in the sense that if you think the public guys don't really care so much about competing, but they're
Right.
still getting better,
Yep.
it made me think about your sort of supportive investigations, where the
Right.
inspector comes and gives me information on basically the production function of increasing my score. And so then maybe it's just like everybody can try and adopt this information, but actually if you're well managed and responsive, you end up adopting it more. So it's not even necessarily this competitive effect. It could be just these already well-performing public places have good management, and when you give them this information, they're able to utilize it.
Yeah, that's the cost of investment is lower, the better off you are, right? In some way. Yeah, absolutely. Other thoughts? So what's the overall impression on whether to push more on the mechanisms or, because it's going to be really hard to figure out what the expectations of closures are for these guys as a result of the regulation. That's where, I think the sticking point is with any of this work.
You have a lot, so I don't know what to say. I'm already kind of crushed under the information that you have done so much, so I don't know.
Okay. I'll take that as a don't push on it too much.
Well, I think you have a lot to
Okay.
wrap yourself around. So
okay, now that's very helpful because we have been struggling with this, and
you've done an amazing amount of work. It's just insane, very impressive. That's all I want to say.
Yeah, the advantage of co-authors, I think, is the right response here. Yeah. Well, thank you. Great.
So Esmeralda, if no one else has, actually, I think there's a question in the chat for Jishnu as well.
Yep. Primary care in India. So we have a paper that's been forthcoming in Social Science and Medicine called Two Indias, where we went to 6,000 villages and counted who provides medical care. So 70% of healthcare providers don't actually have any formal qualifications. And it's a very different setting from Kenya, because in Kenya, we didn't find any place that had private providers but no public providers. In India, the dominant model is private provision without public provision. So I think also thinking about regulation in those settings versus this will be very different.
Are there any other questions for Dr. Das before we begin with the seminar? And just a quick clarification, if you didn't email me beforehand and you want to stay and participate in the pro seminar, please feel free to stay. And you can stay here using the same Zoom link. You don't have to use another Zoom link.
Right. Thanks, Jishnu. Those of us who are not joining for the post seminar are going to leave now. So
okay, great. Hey, thank you so much for coming and for the invitation.
We loved having you, and I think Adriana spoke for all of us that this was like just an incredibly interesting and fascinating paper. So thank you so much for joining us, albeit via Zoom.
Thank you.